Right. Good afternoon, everyone. I'm going to kick us off. Sorry, we're running a bit behind. I had some technical dramas. Craig sorted me out. Thanks, Craig.
You're jumping the queue here. I was supposed to announce you,
My
but
bad.
the man is on top of it. He's announcing himself. So you can go ahead, Dr. James.
Thanks. Right. I'm going to be talking to you today about point of care ultrasound and primary healthcare. And essentially, I'm here to try and convince you to start along your point of care ultrasound journey. And a little bit of background as to who I am and why I'm qualified, I suppose, to talk about this. I'm a family physician. I'm working in the state sector. I work in Cape Town, a hospital called False Bay. I also lecture at UCT. But more importantly, I'm the chair of the South African Academy of Family Physicians Point of Care Ultrasound Special Interest Group, which is what that mouthful of an acronym stands for. And I'm also sponsored by Zebra Medical for this talk. It's a unique experience for me, being paid to give a talk. I think I'm enjoying it. My email address is going to be up at the end, so if anyone else wants to pay me to talk at other stuff, please send me an email. Right, I'm kicking us off with a controversial yet absolutely true statement that the stethoscope that you grew up with medically is obsolete. There are 3 existing uses for your stethoscope. It's identifying wheeze, and that's the only clinical use. It's pretending to be a patella hammer, and it's making sure your patients and staff know that you're the doctor because you've got it around your neck. Otherwise, your stethoscope is obsolete. It was invented more than 200 years ago by that dude in the painting over there, René Lanac, and the concept of it hasn't changed in 200 years. It should have been called the stethosphone because you're listening to what's going on inside, you're not looking. But if you want a scope that does look inside the body, I've got good news. There are some options out there. So the option for you, I'm losing us, Craig. The option for you as a primary care physician is point of care ultrasound. So what is point of care ultrasound? It's ultrasound done by the clinician at the point of consultation with the patient in their consultation room. It's diagnostic or it's procedural. It's used in your consultation with your patient. It's helping you make decisions in real time. It's enhancing what you do with the patient. It's giving you faster management outcomes. Point of care ultrasound is an extension of your clinical exam. It's not a special investigation that you order. It's not somebody that you refer to radiology or ultrasonography for. It's part of your consultation as a clinician. Right, I'm going to try, if it works, a little bit of audience participation, if you guys are up for it. If you are, and you haven't got enough postprandial slumber, can you whip out your phones and join me on menti.com? You can either go to that website or zoom in with your camera on that QR code. It should pick up the link. And then we're going to have a bit of audience participation just to wake us up. I'm seeing some thumbs up. That's good. I'll give another 15 seconds. Many thumbs. Excellent. Right, so in your current practice, as a general practitioner or whatever you are, I want to know how many of you have access to an ultrasound machine. Not an ultrasonographer, not a radiology service who will do an ultrasound for you, but a machine that you can use as a clinician. How many of you in your daily practice have got access to a machine? Okay, we're telling a story. Oh, the yeses are catching up. All right, so it's about a third of you that have got access to a machine, 2/3 of you don't. I'm going to give it, well, we're catching up. All right, I'm going to move on to the next one then, which might not be relevant for those of you who answered no, but in your last 6 months of clinical practice, how often have you made use of ultrasound in your patient consult? Daily, weekly, monthly, maybe once in the last 6 months, or never? I've got to see, am I preaching to the choir, or is this fertile ground? And it looks like we've got a decent range. We've got some nevers. I like the nevers because that means you're going to listen to what I have to say. Okay. All right, so what this graph is telling me is that the rest of my talk will be useful, so that's good. I'm going to crack on. And I'm going to convince you why point of care ultrasound is really useful for primary care. There's a bunch of amazing evidence and research out there. I'm not going to give you all the references because it would take up the entire slide, but I'm just going to walk you through these 6 points. It's point of care ultrasound in your clinical consult as part of your physical exam gives you better diagnostics. You are going to be making more accurate diagnoses if you're using an ultrasound probe as part of your clinical exam. And because you're making better diagnoses, it changes management. Thanks, Craig. Sorry about that. Can you hear me? So you're going into a consult, you've taken your history, you've done a clinical examination, and you've got a list of differentials in your head. Point of care ultrasound can change that differential list, push something right up to the top, rule in a test, rule in a condition that you hadn't thought of, and completely change the direction of your management. I think importantly for our patients is that it results in less referrals or less inappropriate referrals. You're able to manage a large cohort of patients yourself without having to refer on to higher structures. And when you do refer on, you've got a lot more evidence to back up your referral. Gives you safer procedures. This is especially relevant for in-hospital or emergency medicine, but in the primary care consultation, you've got a patient, you think they've got a knee effusion, or are they just really fat? That probe will be able to tell you what you're sticking your needle into. Is it an effusion or is it just adiposity? Same for a morbidly obese patient that might have ascites. Your probe is going to tell you, is there fluid, yes or no, and then it's going to show you where to put that needle in real time. I think one of the most important things for me is that patients love it. And there's some really good evidence looking at patient satisfaction for POCUS-based consultations and consultations without point of care ultrasound, is that hands-on process of point of care ultrasound, having a screen, being able to show the patient in real time what is going on inside their body, makes them think that you are a better doctor, that you're doing a better job, that you're giving them better treatment, even if that's not true, even if you're rubbish. Because you're using point of care ultrasound, the patients think you're cool. And they come away from the consult with much higher satisfaction rates than if you hadn't used point of care ultrasound. And the thing that I relate to most is that I enjoy using it. It makes my clinical practice so much more fun. It's a really interesting tool. It's great for teaching. It enhances your consultation. It makes my day-to-day clinical work much more enjoyable. Right, so just a little bit of background about where we are at internationally. GPs actually kicked off the point of care ultrasound revolution way back in the early 80s with first trimester scans, the rural GPs who pop a probe on and see what was going on with an obstetric patient. That's where family medicine left the point of care ultrasound journey, sadly, and emergency medicine has run with it since the 90s. Critical care, anesthetics, even rheumatology, musculoskeletal, sports exercise medicine are catching on fast. Family medicine and general practice is far behind, especially in South Africa. We're trying to change that. So internationally, in terms of the generalist specialities, the Americans have brought out a really detailed curriculum in 2016 for their family physicians. They made it compulsory in 2022 for their graduates to be POCUS trained. Canadians, Australians, and New Zealanders, as part of their rural generalist network, rural EM family physicians, have all cottoned on to point of care ultrasound. But interestingly, from a GP point of view, is that the Scandinavians and the Eastern Europeans are actually far ahead the rest of us in terms of their use of point of care ultrasound and their production of evidence relating to point of care ultrasound. So this was a study done by a bunch of Scandinavian GPs. It was a systematic needs assessment, and it produced a ranked list of applications for point of care ultrasound in GP practice for all Scandinavian GPs. Gave us a ranked list of 30 applications. I've only included 10, otherwise there'd be too much text on the slide. But you can see the number of uses, the top 10 uses anyway, for GPs with point of care ultrasound. And I'm sure you are looking at that list and thinking of applications in your own clinical practice. I could definitely use it for that. So don't think of this as a hospitalist or an EC-based or a theatre-based skill. This is for all clinicians. So I just want to talk you through 3 use cases for point of care ultrasound, just 3. I want to talk you through the evidence for them and give you a real-world example of it. As a brief stats reminder as to what sensitivity and specificity is, if you can remember back to your med school days, is that there's a useful acronym which simplifies it but helps to understand SPIN and SNOUT. So sensitivity is ruling stuff out. Specificity, spin, is ruling stuff in. So if you've got a really high specificity, it means you can rule in a condition really well. If you've got a really high sensitivity, it means you can rule it out. You can confidently say it's not there. So just in terms of acute heart failure, we know that clinical exam combined with chest x-ray isn't that great for diagnosing acute heart failure. You can see that our sensitivity is in the 70s, specificity is a little bit better, 87%. But if you're combining that with point of care ultrasound, your sensitivity and specificity is in the 90s. And that's a huge difference between clinical exam and who really believes that a raised JVP even exists. I don't know if I've ever seen it. I think it's a myth. Clinical exam plus x-ray, if you add on point of care ultrasound, you're increasing your diagnostic accuracy exponentially. So, you're working in your Randburg GP practice. It's a mixed practice. You have some medical aid patients, you have some cash patients, and this lady who's very well known to you presents. She's a cash patient. She's got a range of comorbidities, including COPD and hypertension, and she comes to your practice with worsening shortness of breath. Her vitals are okay-ish. The sats are maybe close to a baseline. She's got COPD. She's got a bunch of wheezes and creps when you listen with your obsolete ultrasound, except for the wheeze. And you decide that, given her clinical picture, she's often been to before with COPD exacerbations. She's probably just got another COPD exacerbation. You're going to give her oral antibiotics, throw some prednisone in. I won't talk about what oral antibiotics you use. I get to prescribe amoxicillin only, pretty much. I'm sure you guys prescribe fancy things. You give her a neb in your practice if you've got that capability. She's a bit sick, but the patient's not keen for admission at all, so you decide to discharge with her normal MDIs, oral antibiotics, and prednisone. You do safety netting as any good GP would. So this is alternate universe A. Alternate universe B is you've had some point of care ultrasound exposure, and you decide to pop a probe on. And you start off by popping a probe on her lungs. And you've got a nice handheld ultrasound probe that plugs into your phone, and you put a probe on her lungs. And I'm going to stand up here and point at things. I'm obviously not going to teach you how to do lung ultrasound in 3 minutes, but I'm just going to show you what's going on in this image. This is a rib casting a rib shadow, because ultrasound waves can't penetrate bone, so behind the rib is all black. Rib and a rib shadow. On the other side, another rib and a rib shadow. At the top, you've got subcutaneous tissue. Here's some intercostal muscles. And this white line over here, if I take a step back, can you see there's a shimmering white line over there? That's your pleural line. So that's where your visceral and your parietal pleura are rubbing up against each other as your patient breathes. So we can see there's nice movement at that pleural line. Your patient's breathing nicely. They don't have a pneumothorax. But this is your pleural line. These lines down here are reflections of that pleural line. Ultrasound can't penetrate air, so if you have a normal air-filled lung, your ultrasound wave hits that pleural line, bounces back to the probe. Hits the pleural line, bounces back to the probe. Your ultrasound machine gets confused and thinks that there are further pleural lines all the way down your field of vision. There aren't. It's just a reflection of that pleural line showing you that you've got an air-filled lung. So normal lung with A lines, A for air. You reminded yourself this is what a normal lung looks like. On your patient, you put a probe on, and instead of normal lung with A lines, you see this picture. So a reminder that it's rib and rib shadow, subcutaneous tissue, intercostal muscles. This is your pleural line. And instead of seeing the reflection of the pleural line as A lines, we're now seeing, any ideas? What are those things? Why is that? Didn't I tell you this just now? Those are B lines. And they correlate to the concept of curly B lines. So on a chest x-ray, you see curly B lines in pulmonary edema. Same kind of concept. Those are B lines, those white lines starting at the pleural line, shooting all the way down through your field of vision are B lines. And it just means wet lung. So there's fluid in that lung. And if you probe here and you see B lines, and you put a probe here and you see B lines, and here, you got B lines all the way through your chest. Those lungs are wet. All right. You then remind yourself what a normal heart looks like. This is a normal heart. And you put a probe in the patient's heart. Well, you're reminding yourself, this is a parasternal long axis for you. Don't worry about the name. But that's a left atrium and a mitral valve. This is a left ventricle and aorta and aortic outflow tract. So this is your left ventricular posterior wall, that's your septum, and you can see that ventricle is squeezing, right? You don't need to be a cardiologist to see that it's squeezing. It looks like it's doing its job. But on your patient, you pop the probe on, and you see this. And once again, you don't need to be an echo technologist or a cardiologist to see that this left ventricle, so it's the left ventricle posterior wall, that's the septum, is not squeezing at all. That's rubbish. That heart is not doing its job. You can see that mitral valve looks like it's very lonely, not getting anywhere close to the septum. This is a heart that's not squeezing. So on your patient, you've just looked at the lungs, you've seen they look wet. You've just looked at the heart, it's looking rubbish, like it's not doing its job. And that should change your differential diagnosis, and that should change your management. So in this patient, on the left is alternate universe A, where you didn't know anything about point of care ultrasound. You discharged the patient with oral antibiotics. They came back the next day. Terrible respiratory distress. You think, why didn't they go straight to the EC instead of to my GP practice? The vitals are horrible. Maybe she's shocked. Maybe it's a severe pneumonia, so you give a fluid bolus if you've got capability for that, and then the patient dies while they're waiting for ambulance. Whereas alternate universe B, where you've got point of care ultrasound, on the consultation, the first consultation, you give her a sublingual isodal, IV furosemide if you can, you give her captopril, and you refer her to hospital at that same consultation. She gets managed for acute heart failure and discharged on appropriate meds from hospital. Right, so I'm starting to convince you, right? That's 1/3 of the test cases through. Next one, a little bit less scary, a little bit less complicated, but is looking at the diagnosis of abscess versus cellulitis for patients where it's clinically unclear or the clinical exam is difficult or it's an ambiguous setting. If you've got someone with a massive, ripe abscess that looks like it's about to burst, your clinical examination is really good. Your specificity and sensitivity are great. You can see that's a massive abscess. If you've got someone who's morbidly obese and you're not quite sure, then your clinical examination accuracy is worse than if you were flipping a coin. Your sensitivity and specificity are both below 50% for the clinically ambiguous patient. Whereas for that patient that you're not sure of, ultrasound is much better than clinical exam. Interestingly, this is one of the few cases where we use ultrasound to rule stuff out. Most of the time, you're only using point of care ultrasound to rule stuff in. I see there's a DVT. I see there's heart failure. Rather than saying, there's no DVT, it's fine. But for an abscess, if you don't see it on ultrasound, it's not there. The sensitivity is really good for ultrasound. Right, so it's your same patient. She's come back to your practice. She survived her last encounter with you. She's got the same list of comorbidities. She had an insect bite on her abdomen a week ago, and now it's a little bit infected, she thinks. Your clinical exam is hard. She is massively overweight. You think there's cellulitis. Maybe there's an abscess. I can't really tell. It's difficult to examine her. So clinically, you can't exclude an abscess. You're aware of what the evidence says about physical exam and the clinically ambiguous patient. So you say, let me rather be safe than sorry. Let me rather refer her to hospital for the surgeon to have a look. She's a cash-only patient. She doesn't have medical aid. So you have to refer her to the nearest state hospital. I think that's Helen Joseph. I'm not from Joburg. I just Googled. Is it right for Randburg? You refer to Helen Joseph. She waits for 18 hours in EC and eventually absconds because she hasn't been seen. Does it sound familiar? It's definitely familiar for my hospital. Right, so alternate universe A. B. In alternate universe B, you know how to do a bit of ultrasound. And you remind yourself what normal subcutaneous tissue looks like. So this is again with a handheld probe. You've changed the preset to soft tissue. You're seeing subcutaneous tissue here. There's some adiposity. You're seeing a muscle layer over there. You're remembering this is what normal soft tissue looks like. You're also remembering what abscess looks like. And you can see why the sensitivity for abscess on ultrasound is so good, because it's so obvious. On ultrasound, anything that's got fluid in it is black or hypoechoic. So you can see there's a big black thing in all that soft tissue. There's a big hypoechoic cystic lesion in the soft tissue. That's an abscess. That's a classical abscess. So you've reminded yourself what normal skin looks like, you remind yourself what an abscess looks like, and you put a probe on your patient, and this is what you see. And this is called cobblestoning, and it's pathognomonic for cellulitis. This is classic cellulitis. So you see all the fluid is infiltrating in between the soft tissue over there, giving you that kind of cobblestone road picture. So you know what an abscess looks like. You didn't see an abscess, you saw cellulitis instead. So universe A, no ultrasound. You sent her to hospital, she absconded because she waited for 18 hours. She comes back 5 days later with extensive cellulitis. You have to refer her back to hospital for IV antibiotics. She hated her Helen Joseph experience, so she has to borrow money, and you send her to Olivedale, I think, if you're in Randburg. Some people are shaking their heads. Is that a bad experience with Olivedale? Olivedale. That's bad for the patient. In Universe B, where you've got ultrasound, at your first consult, you confidently excluded an abscess because the sensitivity for point of care ultrasound is 92%. So you could discharge the patient at that consult with oral antibiotics. Once again, we'll debate that. I've only got access to flucloxacillin. And she recovered well. She never needed referral to any hospital, private or state. She never needed an admission. She never needed to borrow money from a relative to get into Olivedale. Am I convincing you guys yet? I've got one more test case, and that's for cholecystitis. So this is another one of the applications that came up on that top 10 list of the Scandinavian GPs. And the evidence for cholecystitis isn't about physical exam versus POCUS. It's more about POCUS versus radiology ultrasonography. POCUS versus the diagnostic radiologist or ultrasonographer done booked scan. And you can see that the numbers vary slightly, but essentially it's exactly the same. That if you are a clinician who's had some ultrasound training and you do point of care ultrasound during your consultation, you are as good as a radiologist in diagnosing cholecystitis. There is no difference. Tell the radiologists that. Once again, it's the same patient. She's back for a third time. She's still alive. She's got the same list of comorbidities. And she's come to you with a week of worsening epigastric pain. She's still morbidly obese. And strangely enough, she's got exactly the same vitals as she had when she had acute heart failure, which is weird. And once again, still difficult to examine. She's run out of her PPIs. She often presents like this. You think it's just a flare of a peptic ulcer disease. Start her back on her PPI, but you're like, was it epigastric? Was it right upper quadrant? Let me just get her a booking for a radiologist done ultrasound. 2 days' time, discharge her with safety netting. Okay, so you know the formula by now. This is alternate universe B, where you've had some ultrasound training, and you remind yourself what a normal gallbladder looks like. You've now got a probe that you put on an abdominal setting or using a curvilinear probe. You're looking through the liver as an acoustic window, and you're seeing a gallbladder. And you're seeing a nice empty gallbladder. It's just black inside. And you're seeing a thin wall of the gallbladder. If you measured it, it would be less than 3 millimeters. This is actually my gallbladder, and you can see that I had a full stomach. It comes through. Wait. That's the beginning of my stomach contents coming through over there. Anyway, that's my gallbladder, and it's normal. You reminded yourself what a normal gallbladder looks like, and you pop a probe on your patient, and instead you're seeing this, which is quite nice and obvious, right? You're looking through the liver again as an acoustic window. You're seeing your gallbladder over here, which has got a really thickened wall. It's more than 3 millimeters, definitely. You're seeing bright white stuff inside the gallbladder, and those bright white things are giving you acoustic shadows. You can see that as you scan over them, there's a black shadow behind them. It's because gallstones are stones, so ultrasound wave, like bone, can't penetrate stones, so you get that acoustic shadow behind them. And while you're there doing the scan, you do an ultrasonographic Murphy's, which is essentially a very directed Murphy's test. Murphy's test is you put your hand where you think the gallbladder is, and you get the patient to breathe in, and if their diaphragm pushes down the gallbladder onto your finger, they go, ah. It's not very sensitive because you don't really know where the gallbladder is. But with an ultrasound probe, you can see exactly where the gallbladder is. You put your probe exactly where the gallbladder is on the ultrasound, and you do the same thing. You get the patient to breathe in, they breathe in, the cholecystitic gallbladder hits your probe. It's very, very specific sign. So for this patient, you've put your probe on, and you've seen thickened gallbladder wall, gallstones. She's got a positive Murphy's ultrasonographic Murphys, you're fairly convinced she's got cholecystitis. On the left, you didn't do a scan. She comes back 2 days later and shocked. You have to refer her to hospital. She has a lap. She has a gangrenous cholecystitis. She's in ICU for a week. On the right, you pick up the diagnosis of cholecystitis on the same day before she's deteriorated, refer her to the surgeons. She gets some IV antibiotics, gets discharged, and gets her nice, stable, elective cholecystectomy 2 months later. Right. So I've given you 3 test cases. There are obviously way more than just 3 use cases, but I've convinced you. I've told you the evidence. I've shown you the real-world application. You agree that point of care ultrasound has replaced your stethoscope. What now? Well, what now is that you need to get yourself an ultrasound machine, right? So, fortunately, technology has moved us along really nicely, and we no longer are reliant on massive cart-based ultrasound machines. If you want to get a fancy cart-based machine, entry level probably starts at about 750,000 Rand. The nice ones are north of $1 million. But there are a range of good quality handheld ultrasound probes out there. The one pictured here is the Butterfly IQ, which is what I use. But there are a number of other options as well. Most of them retailing for just over or just under 100,000 Rand. Some quite a lot less than 100,000 Rand. So for 80,000 Rand, you're essentially getting the same product as if you were spending more than 750,000 Rand. It's much more portable. You can plug it into your phone. You can plug it into a tablet. If you're looking to start on your point of care ultrasound journey, this is the kind of machine that I would start with. Obviously, if you've got cash to burn, buy $1.5 million Rand ultrasound machine that has like a full echo suite or something. But if you're looking for portability and also functionality, a lot of these probes, well, some of these probes are standalone probes where there will just be a cardiac probe or just a curvilinear probe, where some of them have got 3-in-1 capabilities where you can choose from the same probe and it can give you the same functions as if it was 3 different probes. The Butterfly pictured is one example of a kind of probe that is a 3-in-1 probe. Okay, so I've convinced you to get involved in POCUS. You've bought yourself a machine, a handheld probe. What next? Next is you need some training. There are a lot of excellent one-day in-person workshops run by a bunch of different entities across South Africa. I chair the South African Academy of Family Physicians. Here's the logo. I've got to point it out to you. I chair the Point of Care Ultrasound Special Interest Group for that. Seems to be working fine. And we run one-day workshops throughout the year. The next one is in May, and we're also running one in Midrand in September. But all of these other organizations, and there are others that I haven't listed, who run a similar introduction to point of care ultrasound in-person workshop for a day. And that's a great place to start. It'll give you an introduction, teach you how to use a probe, and start you off on some basic applications of it. Once you've got a probe, you've got some basic training, then you've got to start thinking of where your kind of niche area is and how to apply it. So when we're starting off with basics, there's a really nice guide that was published in an American journal, The Family Practice Management, giving guidance on how general practitioners or primary care physicians should start off with ultrasound. And the general idea is to start off with easy scans that have low liability for you and for the patient, and then work your way up from there. So if you want to start off with skin and soft tissue and you're doing cellulitis versus abscess, like I just talked about, and then you can move on to some more diagnostic lumps and bumps stuff. If you're looking at the abdomen, you can start off by just looking to see if there's free fluid or not, is there ascites or not. And you can work your way into procedural stuff, maybe tapping the ascites, maybe looking for hydronephrosis. If you're looking at the chest, you can start off by just looking to see if there's a diffusion or not, and then you can work your way up procedural, looking for pulmonary edema. So this is a nice way to think about how I start using point of care ultrasound in my practice, and I would start off with what's easy and what's less risky. So you've had some training, you've got a probe, you're making use of some low liability applications of it, but you want to develop your scope a bit more and get a bit more education. What's next? There are a lot of online educational content platforms available. This is one that I've used the most. It's when you purchase a Butterfly probe, you get access to their Butterfly educational content, as well as a concept called Scan Lab, which essentially takes you through the steps of how you do a scan and teaches you how to do a scan in real time, shows you, is that a good image, is it a bad image? And through the Butterfly Academy, there's various courses on all sorts of point of care ultrasound applications, from cardiac to soft tissue, dermatological, rheumatological, emergency medicine, etc. There are a number of other online platforms as well. POCUS 101, Global Ultrasound Institute, the Ultrasound Leadership Academy. So if you just look online, you're going to find a bunch of stuff. This is one of the very excellent resources that you get from Butterfly. And I think that's basically me. I wanted to give a little bit of time for any questions if there were. I've been brave and I've put up my email address for if anyone has any questions. I used to be very active on Twitter, posting a lot of POCUS stuff, but since Elon Musk took over, it's turned into a bit of a cesspool of right-wing porn bots. So now I'm just on email. I've lost my social media home. Please send me an email if you've got any questions. If it's related to primary care, family medicine, GP practice, and ultrasound, then I'm your guy. I'm the one that's interested. We're trying to drive this from an Academy of Family Physicians perspective. So I'm very happy to take any questions now, or if you think of them later and you want to send me an email. List of references which you're obliged to stick in your slide, not that anyone ever reads them. And I think that's pretty much me. So,
any questions from anybody?
Any questions?